Hello and welcome to Everyday Medicine. I'm Dr. Luke. I'd like to thank you all for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable to our medical practices. In this episode, we're talking with an expert on the subject of perimenopause, menopause and menopausal hormone replacement therapy. Before we start, for Australian audiences, listening does give you eligibility for your CPD, so log in and make this an activity. You can also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, it's now increasingly recognised that women's healthcare needs at menopause have been both under-recognised and under-treated by medical practitioners, and that menopause management has not been emphasised adequately in graduate and postgraduate education. Well, considering that half the world's population spend about a third of their lives after menopause, this unmet need must be recognised and addressed. Well, I was curious to explore this subject in greater detail and welcomed the opportunity to review some basic science and definitions. Menopause, also known as the climacteric, is the time when menstrual periods permanently stop, marking the end of the reproductive stage for females. It typically occurs between the ages of 45 and 55 years and is often defined as having occurred when a woman has not had any menstrual bleeding for a year. Perimenopause is the natural stage in a woman's life occurring before the final menstrual period, or menopause, when a woman's body transitions away from its reproductive years. And the stages of reproductive aging workshop system, so-called STRAW plus 10, is a defined set of nomenclature which describes the stages of ovarian aging. Based on these criteria, perimenopause starts when there are persistent differences in cycle length of 7 or more days between consecutive cycles and continues until 12 months after the last menstrual period. During this time, the ovaries gradually become less functional, leading to changes in menstrual cycles and potential infertility. Well, many women have physical and emotional symptoms during perimenopause. However, every woman will experience symptoms differently. About 20% have no symptoms, while 60% experience moderate symptoms. The remaining 20% have severe symptoms that interfere with daily life. The perimenopause is characterised by fluctuating estrogen levels. They may be high or low. And symptoms may reflect those associated with either estrogen excess or estrogen deficiency. So mastalgia, heavy menstrual bleeding and headaches are associated with estrogen excess, whilst symptoms of estrogen deficiency include vasomotor symptoms, sleep disturbance, mood changes, fatigue, cognitive concerns, low libido, genitourinary symptoms, arthralgia and myalgia. Perimenopause is a time also when risk factors for chronic disease need to be considered, including acceleration of bone loss, increasing cardiovascular risk arising from adverse changes in lipids and altered glucose metabolism, as well as possible development of central adiposity. Cancer screening programs, including bowel, breast and cervical cancer, should also be discussed with patients at this time. Medical treatment of perimenopause and menopause is aimed at ameliorating symptoms and to prevent bone loss, and is centred on the use of menopausal hormone therapy, so-called MHT, with the replacement of estrogens either alone, in the case of previous hysterectomy, or combined with progesterone when the uterus is present. Other simple advice, including avoiding nicotine, caffeine and alcohol, as well as the use of selective serotonin reuptake inhibitors and meditation, could be considered. Well, in relation to prevention of menopausal-associated bone loss, the use of MHT has demonstrated a 4 to 6% increase in lumbar spine density and 2 to 4% improvement in hip density over 2 to 3 years, with a reduction in vertebral fractures by 35 to 40% and hip fractures by 25 to 30%. Bone loss does resume after therapy withdrawal, however, which is not the case when biphosphonates are used, as they have a long-lasting effect. Many of the concerns about MHT raised by older studies are no longer considered barriers to its use in healthy women. The risks arise around discussions of breast cancer, uterine cancer, and cardiovascular disease, including thromboembolic events and strokes. Well, regarding breast cancer, the average risk for 1,000 women aged 50 to 59 years is 23 per 1,000. If these same women were administered combined MHT, there would be an extra 4 cases, the same increased risk as for women on the combined oral contraceptive pill. Significantly, however, studies reveal there would be 4 fewer cases for women receiving transdermal estrogen-only therapy. That is, transdermal estrogen appears to be protective. It's important to note that there would be 5 extra cases for women consuming 2 or more units of alcohol per day, 3 extra cases per 1,000 for smokers, and 24 extra per 1,000 for women with a BMI greater than 30 kilograms per metre squared. Exercise reduces the risk by 7 cases per 1,000 when 2.5 hours of moderate exercise is undertaken per week. Well, the risk for uterine cancer only relates to the use of unopposed estrogen when cyclical or continuous progesterone should be used, but is not. In this ill-advised circumstance, the risk of uterine cancer is 4 to 8 times the baseline risk after 5 to 10 years. Unopposed estrogen is unsafe with an intact uterus. For cardiovascular disease, the evidence pertaining to MHT risk relates to timing and the use of oral rather than transdermal estrogen. If oral or transdermal estrogen therapy is initiated within 10 years or earlier since menopause, or less than age 60 years, there may be a slightly reduced coronary artery disease risk. Initiation of MHT using transdermal estrogen more than 10 years after menopause, or after the age of 60 years, does not increase the cardiovascular, stroke, or venothrombotic risk. However, there does appear to be an increased risk if oral estrogen is used instead, where the stroke risk is increased in that instance by 30 to 40%. That's 2 to 4 per 1,000, and venothrombotic events in that instance by 2 to 3-fold per 1,000 increase. Interestingly, recent studies have also demonstrated that women using MHT have a 30% reduction in the risk of developing esophageal and gastric cancers, strengthening the link between hormones and tumour development in the upper gastrointestinal tract. Molecular mechanisms are not fully understood at this stage, and their elucidation remains eagerly awaited. Well, with this background, I'd like to introduce Dr Sugandha Kumar. Dr Kumar is an obstetrician and gynaecologist committed to providing comprehensive women's health care in the southeastern Melbourne suburbs. Sugandha did her early specialist training at a prestigious medical institute in India and completed her advanced training in obstetrics and gynaecology in Australia at Monash and Eastern Health. She holds special appointments at Box Hill Appointment and has a strong focus in improving outcomes for her patients by offering up-to-date and evidence-based treatment options. She provides obstetric, gynecological care and is expert in advanced laparoscopic surgery, including laparoscopic hysterectomy and endometriosis surgery, as well as having a specialist interest in menopausal hormone therapy. Well, please welcome Sugandha to the podcast, which we will now present in 2 parts. Dr. Sugandha, thank you for joining me on Everyday Medicine. It's extremely kind of you to make your time available to talk about menopause, a very important subject. And as we've mentioned before recording, this is a passion for you to discuss, and we're so grateful to have your expertise along and to share that with the audience tonight. And we're going to break this into 2 sections. The first section talking about menopause, premenopause, and then the second section, which we'll produce as a second recording, will be on treatment. So, Sugandha, thank you very much. I'd like to hear a little bit about your journey into gynecology and how you became interested in this aspect of gynecological medicine.
Thank you, Luke. It's a pleasure to speak to you. I'm an obstetrician and gynecologist and love what I do. I love working with people, love working with women, and have been doing a broad range of gynecology work, including fertility, laparoscopic surgery, of course, menstrual abnormalities and things. And then I can reflect on how I got interested in menopause was in early days of my private practice when I met these women who were clearly struggling with menopause symptoms and really wanted something to be done or something to be prescribed. And I recognized that, but I was very ill-equipped to offer anything And in the background of that, I started my obs and gynae training in 2002. And that's the year when the HRT almost died, or hormonal therapy for menopause almost died after the now well-known Women's Health Initiative study.
Yes.
So 2002 was the year when everyone just stopped prescribing and took away the hormone replacement from those women who were even wanted it at the time. So all my training, I didn't learn anything about MHT, HRT. We knew about menopause and we knew about some symptoms, but we were doing other things. And many, many years down the lane, when I saw some women in private practice and I really wanted to offer something, so I educated myself and then started offering MHT. And I can't really be more surprised to see my patients coming back 3 months later, really put together, makeup on, really happy, bringing me a box of chocolate. And that touched me as, that will be me. Not long from now, that will be me. So I think just the patient profile, a little bit of personal stake in this natural aging process. I started looking into it. And I realized that tide is turning. There's a lot being done. Women are asking about menopause management. The social media has changed a lot. The women's voice is being heard. And truly, there's a huge unmet need. Half of human population will spend 1/3 of their life in menopause.
Yes.
There's a huge amount of health need. So that got me started a few years down the lane. I'm not expert by any means, but I really am passionate and I do practice and I have a dedicated patient base who keep returning to me and are very, very happy. And I'm very pleased to see what I can offer to
Thank you.
women.
Well, thank you very much. And we're so lucky to have people that are passionate about this subject because, as you say, it's a very, very common subject. And I have the impression, and this is certainly no criticism of anyone in private practice, in primary practice, that maybe it's not handled quite as well as some ladies would like. And probably it has a lot to do with the concerns around hormone replacement therapy too, which we'll talk about a little later on. Can you just update us on these two terms, premenopause and menopause? What are they exactly? How do we recognise these aspects of ladies going through this hormonal decline?
Sure. So there is a general understanding in population as well that menopause is end of a woman's menstrual cycles, end of reproductive ability. So in medicine, it's a little bit of a retrospective diagnosis. So absence of menstrual periods for 12 months is menopause.
Right.
So actually it's the last period, which is the last period, but we can only diagnose it as last once 12 months have passed. So that's, we sort of look back at it and that's how we diagnose it. The time before that is premenopause, or more commonly called perimenopause. We're transitioning into the menopause, and that time some symptoms are happening, hormonal changes are happening, and most women can recognize that
At
they are.
what sort of age are we talking here in general?
So average age of menopause in Australia is about 51 years of age.
Right.
But it depends on ethnicity as well and various other factors. The transition or the perimenopause could start anywhere between 45 years of age approximately and can last 4 to 7 to 8 years of transition in terms of symptoms, changing menstrual cycles, and reducing or declining fertility.
So what is happening to the menstrual cycles in that premenopausal phase? Are they becoming a bit shorter, shorter intervals, a little bit lighter? What sort of things are the patients going to typically tell us?
So the most common symptom is irregularity of cycles.
Yes.
And you mainly see infrequent cycles. So the women start skipping a
Right.
cycle or two at a time.
Yes.
Some will have a shorter cycle in the sense they are having more frequent cycles, and that's also seen. Many women struggle with heavier bleeding or passing clots, getting iron deficient. That can also be a sign of perimenopause, but we often also want to look at, do they have other associated pathologies such as fibroids or adenomyosis
Yes.
or polyp, endometrial polyp, things like that. So the menstrual cycle change, most often skipping them is the most common symptom.
So again, when we talk about hot flashes and a lot of these other very concerning symptoms that ladies have with mood changes and so forth. When does that so is that something we're going to see in the premenopause, or is that indicating that there's been a greater decline in the ovarian function and we're now really in our menopausal sort of state?
It certainly starts before menopause. So we're talking perimenopause here. Hot flashes or hot flushes and night sweats related to each other. They happen way before the actual finishing of your menstrual cycle. And they're related to estrogen decline. And we know that perimenopause, the hormonal cycles are a little bit erratic. So there are some times when there is a huge rise in estrogen, and women can feel breast tenderness, heavier bleeding in that cycle. But then there is a following period where there is decline in estrogen. So they feel symptoms like hot flushes, night sweats, vaginal dryness, reduced energy, things like that. And that happens sort of irregular fashion. And often women will come and say, I feel well for a month and then I feel really down for the next 2, 3 months. So it's irregular.
Okay, thank you. Well, I'm curious to know, when patients come to you, and I'm guessing they're being referred to, of course, but what are they asking you? Are they asking you for proof? And then I'm interested to see what tests you recommend. But what sort of things are they asking you when they come in?
Yeah. Most women have an idea of
Yes.
what's happening to them. They know themselves that it's a perimenopause or menopause. They have probably done a little bit of research themselves. They've spoken to their GP and they're referred on. So by the time they come to me, most of the time they're looking for some therapy.
Yes.
They have significant symptoms. They're wanting to discuss MHT or even non-hormonal methods if they've tried other things and they haven't got enough relief.
So,
And I find often they want to come and see me because they are worried about MHT. The GP has offered or they've read about it, but they're so worried about
yes,
cancers and other things. And
yeah.
yeah.
So that there's a lot of assurance and another, like, professional opinion that they're asking. Do you tend to launch into a variety of hormonal tests at this point to prove that it is an ovarian decline stroke failure? Specifically, what should be ordered? What should we be thinking in primary clinical practice?
Yeah. So in the usual age for menopause, straightforward symptoms, we actually do not need any blood test to diagnose menopause. So a woman who is more than 45 years of age is experiencing some irregularity of menstrual cycles, has symptoms of what we call vasomotor symptoms such as night sweats or hot flushes, and other symptoms which are very, very common is poor libido, poor energy, weight gain, and something called brain fog. So they really feel they're cognitively not as sharp as they used to be. Hard to define, but generally these symptoms, they don't need any blood test for hormonal profile to diagnose a woman. And generally you can make a clinical diagnosis and start therapy, whatever that may be. However, if a woman's younger, under 45 years, or in particular under 40 years of age, so premature menopause, you do want to confirm by doing a serum FSH, so follicle stimulating hormone, estrogen, and any other test that might be coming up in your clinical history for the patient, because many symptoms are vague. This might be hypothyroidism. It might be
Mm.
hyperthyroidism. It might be undiagnosed diabetes.
Yes.
It might be primary mental health issue, a depression issue with energy and sleep and things like that. So the tests are needed for those, not to diagnose menopause. But then there's a good number of tests that should be considered and offered as a general check, as an opportunity for a well-being check for the woman. So you do want to see or check their blood pressure, want to test them for diabetes, their cholesterol, vitamin D, so their nutritional status. So all those are complementary tests, but not for diagnosis.
Yes. Okay. And if we consider the FSH and the estradiol levels, the FSH should be high, and the estradiol levels
Should be high.
are going to be, so the estradiol is going to be high in premenopause because it's being stimulated by the FSH. Just help us interpret
So
what are we going to
estradiol,
see?
yes, sure. So normally in a menstrual cycle, the FSH is secreted by brain, the pituitary gland, and that goes and stimulates the ovaries to start a cycle, make an egg, and produce estrogen.
Yes.
When ovaries are, we're running out of eggs, the pituitary increases the stimulation, so FSH goes up in an effort to start a cycle. So when a cycle does start, it may be prolonged or longer, and at some time there can be a really high estrogen as well. So there's a huge range for estrogen number. It depends on when you took the test, what time of the day, and what time of the cycle. So it's not unusual to find a really high estradiol level if you are testing a perimenopausal woman.
Yes.
It can also be very low. Depends on when the sample was taken.
I see.
It adds nothing of diagnostic value.
I see. So whereas if it was menopausal, I think you're advising perhaps we don't need to do these tests, but then the FSH should be high and the estradiol is going to be low pretty much all the time, whether you measure it on a Monday or Friday or whatever, it's going to be low because we've got that ovarian failure. I see. But in general, thank you for that. We don't really need to be troubled by measuring all these tests. Unless the person is young, and as you say, there may be other factors. Yes. What if the patient comes in and they're later 50s, perhaps this is very unlikely, but they're still saying to you, doctor, I'm still experiencing menstrual cycles. Is that a concern, or is that anything that needs to be evaluated? Could it imply some other pathology in the ovaries?
So many women do continue to have their periods till 53, 54, even 55 years of age. Yes. So 51 is average age, and then there is a distribution around that time. So women who are having cycles in their sort of mid-50s, if there's no other problem, we don't need to investigate. However, if they have other associated issues such as high BMI or diabetes, or they're taking any hormonal treatment or supplements, anything that worries the patient, we do want to really just make sure what's the uterine lining doing, I guess. The ongoing bleeding, is it a regular menstrual cycle? That's not very common at 55 years of age, but they are skipping some and having a bleeding that's concerning. I will investigate to make sure they haven't got a uterine tumor or something like that. And in absence of that, that's fine. Yeah, some women do continue at that age.
One of the things that is talked about a lot in primary medicine is the bone loss that occurs in relation to the menopause, and that ladies have this accelerated bone loss, which can be very tragic with premature fractures and so forth. Can you talk a little bit about how you investigate that? How should we be doing DEXA scans on every patient that's going through menopause, and then what your advice is to patients?
At the moment, there is no guideline to do a DEXA for all women after menopause. If they have additional risk factors such as family history, very low BMI, medical disorders like celiac disease or hyperparathyroidism, or if they have been on long-term steroids, all the usual factors, then a DEXA is indicated to do their bone mineral density or an unprovoked fracture. But menopause by itself is not an indication at the moment. In fact, the Medicare will not pay for many of these indications, even in singularly. I guess what we would call an average risk woman for osteoporosis, DEXA is not indicated. If a woman wants it, this can be done, but they have to pay for it.
Yes.
Yeah. But certainly there is accelerated bone mineral density loss after menopause because of declining estrogen levels.
Is there an effect that we can predict for women who've undergone hysterectomy? Ovaries have been spared. They've undergone hysterectomy at a premenopausal age. What do we see in regard to the menopause in those patients?
So a hysterectomy before menopause, where ovaries have been conserved, should not make any change to the woman's natural age of menopause, whatever that may be for that person. There are some reports of early menopause after a hysterectomy, even if ovaries are conserved. I guess that's related to a little bit of surgical complication where some ovarian blood supply may have been compromised because the hysterectomy was surgically challenging. Or if there was other tumors or cystectomies have been done on ovaries because there were cysts or endometriosis. But if healthy ovaries have been conserved with their blood supply, the women will undergo menopause at the age they are meant to have menopause.
So they can be confident of that. Is there a very significant ethnic difference in terms of when women go through the menopause? Is that something we've observed between, there are a lot of Asian patients now in Australia that's got a Caucasian background and so forth. Do you see much difference across different ethnicities? I'm just curious to know if that's an observation.
It's known that Asians and Southeast Asian women may undergo menopause slightly earlier, so
Right.
1 to 2 years on an average, and may have slightly longer transition and more symptoms. Certainly, women with African background are known to have a longer perimenopause and more symptoms.
Sugandha, I'm reading this book. It's a very short history of Earth, which is quite interesting. And
Yes.
by someone called G, and it won a science prize. It's quite short, but I found it fascinating. He talks about menopause briefly in this book, actually, and he says that humans, as mammals, a little bit unique, where most mammals seem to have undergone a different kind of evolution, but in humans, the adaptation has been that when women go through menopause, we live on, we live on.
Yes.
Whereas in other mammals and other species, whatever the equivalent of menopause is in other species, they tend eventually to curl up their toes and die prematurely because I guess biology doesn't think that they've only got any use anymore. Whereas grandmothers, very helpful in raising young, and in fact can raise more young than have babies themselves. So I'm not sure. I think that's very interesting sort of adaptation and part of natural selection that we're seeing in humans. I found that quite interesting.
It is. And we all think about it philosophically. Why would a human female live after menopause? But yes, maybe they are grandmothers, they can be mentors,
Yes, yes,
ensure the longevity of their children, their
yes,
families. And also it's an opportunity for women, and that's somewhere I read and I really like it. The hormonal veil is gone and you are a wiser, more confident person who can now live on your own. And that's a really good way of looking at it. It's not all doom and gloom.
yes, that's right. Well, our senior citizens all have a lot to offer, even when they've been through the
Yeah.
menopause. And I guess for guys, I don't know, we probably have very little to offer. But Sugandha, thank you so much. I'd like to come back and then in the second part of this, talk a little bit about the treatments, hormone replacement therapy, because that's another very interesting subject. So thank you very much. I'll welcome you back when you have time to discuss that. Thank you so much.
Thank you, Luke. Look forward to it.
Thank you. I'd like to thank you for joining me in the first part of this podcast conversation with Dr. Sugandha Kumar on menopause, perimenopause, and menopausal hormone replacement therapy, which I found fascinating. Please join us for the second part, which will be released in the near future. Also note that during the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as a general information platform only, and they reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@geohealth.com.au. Thank you.